Technical team, please start the countdown.
Okay. So, sir, we are going live in 3, 2, 1. Please start, sir. We are live.
Namaskar and good evening, everyone. Today, I, Utkarsh, welcome you all for today's webinar, Oncology Updates. And with immense pleasure, I would like to invite Dr. Abhishek Pathak, who is a consultant at Medical Oncology, Command Hospital, Calcutta. Over to you, sir.
Hi, Utkarsh. Thank you, organizers, for this wonderful evening. I think we have got great stalwarts from Rajiv Gandhi and also from Kolkata, who would be, discussing about the various aspects of lung cancer. And as we all are aware that it's a major issue, and there are so many aspects that even if we keep on, discussing even one important aspect, it would be taking multiple CMEs. Nevertheless, I feel that we are very privileged to have very eminent speakers among us. And I would invite Dr. Shushankar Sharma from Shushankar Swami, sorry, Shiva, for the first talk, which is on the role of, I think, bevacizumab in CLN. So over to you, Dr. Shiva.
Thank you, sir.
Sorry, Shiva. As always, I tend to make this mistake.
It's okay, sir. I understand.
Good to see you. Very nice.
Same here, sir. I think we should keep meeting more often. Otherwise, probably you'll forget us.
Good. Looking forward to your talk.
Yes, sir. I'm just sharing my screen, sir. Hope my screen is visible and I am audible.
Yeah.
Good evening, everyone, and thank you, Abhishek sir, for inviting me to deliver this talk. And I've been asked to discuss about role of bevacizumab in non-small cell lung cancer. So before moving into bevacizumab per se, I'd like to just touch upon non-small cell lung cancer. We all know that there is a Globocon registry which look at the epidemiology of various cancers. As per Globocon 2020, lung cancer stands at fourth rank among both sexes in terms of incidences. If you look at in men, it is second only to lip and oral cavity. So it is one of the common cancers we come across in OPDs. So non-small cell lung cancer is not a one entity. It encompasses heterogeneous group of diseases. Earlier, we used to divide it based on morphology like squamous, non-squamous like adeno, large cell neuroendocrine, not otherwise specified. However, with the advent of technology, now we have moved on to molecular classifications based on the available oncodicted tumors. So this is how the landscape of non-small cell lung cancer evolved over years. In the 20th century, the treatment of non-small cell lung cancer was mainly chemotherapy. However, with the beginning of 21st century, angiogenics played a very important role in the management of non-small cell lung cancer. However, with molecular therapy and immune therapy, the role of angiogenics has drastically reduced in the recent years. But still, where do we still use bevacizumab in current scenario will be the today's discussion. So basically in non-small cell lung cancer in metastatic condition, we divide the treatment approach into whether they are driver mutation positive or driver mutation negative. In driver mutation negative non-squamous cell lung cancer, this is how the NCCN looks in 2023. Basically, we base it upon the PDL1 score. If it is very high, that is more than 50%, single agent IO would suffice. If it is less than 50%, IO plus chemo is usually the preferred choice. Among them, the one option is atezolizumab, carboplatin, paclitaxel, and bevacizumab. It is a category 1 indication in such scenario, particularly if the PS is 0-1. So the basis for this particular combination is from the HIAM Power 150 trial, which basically had a 3-arm, which looked at the role of atezolizumab, bevacizumab in combination with the chemotherapy. So how does this bevacizumab act on when we add it in the era of, we know that not only in lung cancer, across various tumors, IO combination plus anti-angiogenics is coming up in big way, be it a hepatocellular carcinoma or RCC. There seems to be some kind of synergistic action between IO and anti-angiogenics. So how does this interplay happen? Bevacizumab inhibits, we all know, it inhibits a VEGF-mediated suppression of dendritic cell maturation, enabling efficient priming and activation of T cell response. This is one of the proposed hypotheses. Apart from that, chemotherapy-induced immunogenic cell death can trigger the release of tumor antigens. This is why we combine chemo along with the IO. Bevacizumab also normalizes tumor vasculature. So it improves delivery of not only drugs, also the infiltration of immune cells like T cells into the tumor. Bevacizumab decreases the activity of certain immune suppressive cells like T regulator cells and enables reprogramming of the tumor microenvironment. So with these set of actions, probably it is hypothesized that if we add a IO to anti-angiogenics, there will be a synergistic action and it may improve overall outcomes. This was the hypothesis behind such combinations. So in the particular trial, if you look at the baseline characteristics, they are quite well balanced across, and it was stratified based upon the PD-L1 status, and also they looked at the liver metastasis. We know that in non-small cell lung cancer, if they have a baseline liver metastasis, the response to single agent IO is not very good. This is one of the probably a marker which suggests that probably patient may not benefit from single agent IO if patient have a baseline liver metastasis. In this particular, they also included stratification based on the baseline liver metastasis, and 14% of patients had liver metastasis. So coming to the outcome, in the outcome, if we can see very well that if we add atezolizumab to this Bev plus chemotherapy, it improved. It improved the overall survival. At 12 months, there was a 6% improvement, and we all know that whenever we use a IO, the story lies in the tail end of the curve. As we can see, as it's going, it is separating, and at 2 years, there is a roughly around 9% improvement in the OS. So if you look at the various arm, if you look at the arm in which bevacizumab was not used versus bevacizumab was used, again, there is an improvement in the response rates, and also there is an improvement in the duration of response. In arm A, there was no bevacizumab. In arm B, there was a bevacizumab. So not only atezolizumab, bevacizumab addition also has led to improvement in the response rates as well as duration of response. So if you look at the OS benefit was observed across all PD-L1 subgroups. If you see among the PD-L1 high, that in the atezolizumab trial, it was either IC3, that is more than 10%, or TC3, which is more than 50%. The benefit was pronounced in this particular subgroup. So another important factor which they looked at was how did the patient who had liver metastasis behaved with addition of atezolizumab. Again, this combination definitely improved the outcomes even among the patients who had liver metastasis at baseline. Probably this is one of the reason where probably we may tend to use this these kind of combinations if somebody had liver metastasis at baseline. So even there was a overall survival benefit by using this 4-drug combination compared to without atezolizumab. And also, if you look at the arm A versus arm C, wherein there was only bevacizumab was used and there was no atezolizumab. In arm A, there was no bevacizumab. In arm C, there was no atezolizumab. If you look at the curves were similar, whether either atezolizumab was used or bevacizumab was used. So combination did definitely improve the outcomes. So addition of bevacizumab to atezolizumab plus chemotherapy improved objective response rates and duration of response in patients with liver metastasis. So definitely in this particular subset, we might use this particular combination. So if you look at the safety profile, definitely if we tend to use a more number of drugs, the safety concerns will go high up. If you add a immunotherapy, there will be more immune-related adverse events. If you had a bevacizumab, there will be more proteinuria, hypertension, and risk of thromboembolism as well as bleeding tendencies. One important thing, whenever we choose a bevacizumab in a non-small cell lung cancer, we should keep in mind if patient is already having hemoptysis, we should not use. In central tumors, if it is encroaching upon the large vessels, then we should not use bevacizumab. And also in squamous cell carcinoma, we do not use bevacizumab. So to summarize this particular trial, there was a 5 months OS benefit if 4-drug combination was used. And it also was active in EGFR mutation and as well as liver metastasis patients. So what if, majority of our patients, in particularly in Indian scenario, will not be affording these costly IO agents. So if contraindication for IO, then the treatment option is chemotherapy plus angiogenics. So the various trials which looked at the role of bevacizumab along with chemotherapy, one such is E4599 trial. It showed that addition of bevacizumab leads to 4 months OS improvement. Similarly, AVAIL trial looked at the role of bevacizumab. Again, in AVAIL trial, there was a improvement of PFS from 6.1 to 6.66 months, whether it was 15 mg per kg or 7.5 mg per kg, there was an improvement. And median OS also roughly it was not statistically significant. It was improved to the tune of roughly around 15 days. So another trial, AVAPRIL trial, basically looked at the role of maintenance bevacizumab. It showed that continued maintenance bev plus pemetrexed had a much more advantage than continuing maintenance bevacizumab alone. Similarly, Point Break also suggested that if we plan to continue, it should be both pem plus bevacizumab rather than bev alone. So that was about the non-small cell lung cancer without driver mutations. What about is there a role of this bevacizumab with EGFR mutated non-small cell lung cancer? Yes, it also plays has a role in EGFR mutated non-small cell lung cancer. In NCCN 2023, we find a place for erlotinib plus bevacizumab in EGFR mutated adenocarcinoma lung. So the first phase 2 trial that supported this kind of combination is a JO25567. In this trial, we can very well see that addition of bevacizumab to erlotinib, there was a dramatic improvement in median PFS from 9.8 to 16.4 months. However, the median OS was not different whether we use a erlotinib alone or erlotinib plus bevacizumab. Again, if you look at the tail end of the curves are separating. And if you look at 5 years, there is a roughly around 4 to 5% difference improvement if we add on bevacizumab. So after this, there was a phase 3 trial, that is NEG 026, which looked at again the role of bevacizumab if added to erlotinib. This is a update in 2021, which again showed that addition of bevacizumab to erlotinib has resulted in a 4 months improvement in median PFS, particularly in the exon 19 deletion. However, we all know that whenever we use a first generation IGFR TKs, the exon 21 do well, but exon 19 do well, but exon 21, they do not do as good as exon 19 deletion. So in that particular setting, the addition of bevacizumab had also resulted in a improvement in PFS from 13.7 to 17.4 months. Probably in exon 21, if they are not a candidate for a costly osimertinib such combination, probably these combinations look attractive. So this is a real world data of use of EGFR TK in combination with bevacizumab. Again, in this trial, they concluded that addition of bevacizumab to erlotinib did not improve in PFS in this real world data. However, there was a dramatic improvement in OS, and this particular improvement in OS was much more pronounced in patients who had a brain metastasis. We also in clinical settings, if somebody is on EGFR TK and they progress particularly only in brain, and probably we irradiate, and if we add up on bevacizumab, probably they also tend to do well. So to conclude my talk, the role of bevacizumab has dramatically reduced in the recent years with the advent of targeted therapy as well as IO. However, still it plays a role in certain settings. IM Power 150 has concluded that Atezo Bev plus CP, particularly in patients who had a liver metastasis, it has shown to improve PFS, it has shown to OS, and also it has shown to improve OS across all PDL1 status in non-small cell lung cancer, non-squamous histology. And in EGFR mutated lung cancer, addition of bevacizumab to first generation TKA also improves PFS. And also particularly in patients who had a brain metastasis, they tend to derive benefit by addition of such combinations. With that, I conclude my talk. Thank you.
Wonderful, Dr. Swami, as usual, very crisp and to the point. I just had one question, like, what's your actual experience with giving this ABCP regime? Like, I have heard very different kind of comments. Some people feel it's very toxic. Some say that it's not so toxic. So what's your...
Definitely, sir. A few things with the use of such combination. One, we should have a very good PS patient. Second thing is cost. Bevacizumab also adds on to the cost. Already, many of our patients are not willing for atezolizumab itself. So use of such combinations is very, very limited. I had just seen one patient who was on ABCP, and he almost for a year or so, he was on that combination. Apart from that, even my experience with such combination is very is almost nil.
Yeah, even same here. I am, though cost is not an issue for me, but I have yet not crossed over to that part to give ABCP, but maybe I'll try in one of the cases. And as you rightly brought in, that there is a good data in case we have liver mets.
Yes.
So maybe my next liver mets patient, I'll try that. So amazing as usual. I think if there are any other questions from anyone? I think there are none. So I think we'll go to the next session, and I would request Dr. Upasana to please take over.
Sorry, thank you so much, sir. Good evening. It's an honor to be a part of this wonderful webinar today, and thank you for giving the opportunity for presenting. So I would again request the organizers to please share my slides.
Yes, ma'am. Yes, ma'am. Just give me a moment, ma'am.
So for the purpose of network, if I can keep my video off, is that feasible?
I think please go ahead.
Okay.
You can switch off.
That's not a problem.
Okay, thank you so much. So after this wonderful talk by our previous speaker, so we will again get an insight to what we have been doing with the basic chemotherapy part. So it is we mostly is this this is the kind of clinical practice that we take up once the patient present us. But again, having said that, the role of the targeted therapies and the TKIs have really given us a very good and a significant benefit. So that is what has changed the scenario in the last few years in the treatment of metastatic lung cancer. But we will be more emphasizing on the basic chemotherapy, which we all practice. So coming on to the role and the updates in chemotherapy in lung cancer. Thank you once again, sir, and the organizers for giving me an opportunity. So next slide, please. So we already know the burden of lung cancer in India as per the Globocon 2020 data, which where lung cancer scores the highest for the mortality rates in India. Next slide, please. So it's the second most common cancer in males, because the highest incidence in India is because of the tobacco habit is the lip and oral cavity, as we all know, and lung cancer scores the second highest. But coming on to the mortality, we know the lung cancer has the highest incidence for as per the Globocon data 2020. Next slide, please. So coming on to the evolution of therapy in lung cancer, the NSCLC was once considered a single disease until the distinct subtypes characteristics were identified. The NSCLC subtype characteristics are clinically relevant for treatment planning from the diagnosis. So as we can see, from the broadly two classifying groups, that is the small and the non-small cell carcinomas, we have again got a histological breakdown to the other subgroups in the non-small cell lung cancers. And finally, the treatment strategies that we all follow is the molecular pathology when we know it is a non-small cell, especially in case of NSCLCs, that is the role of IHCs and NGS with for EGFR AL cross testing. And now the role of PD-L1 has also come in, and we have got good results for in the advanced metastatic stage as well, and the role of tumor mutational burden as well has come in the present scenario. Next slide, please. So in 1980s, an advanced NSCLCs, the central question in 1980s were that whether the chemotherapy prolongs survival in advanced stage or not. And we all know, yes, it does, and cisplatin-based doublets do. But the issues that we usually face is the nausea, vomiting, and the myelosuppression. So coming on to next slide. Next slide, please. So then came the role of other third generation agents like vinorelbine, paclitaxel, gemcitabine, and docetaxel. So again, we got the answer to the next question, which came up in 1990s, whether platinum-based doublets with the third generation agents are superior to the older doublets or not. So this is how the treatment strategy kept evolving. Next slide, please. And now again, we always follow the US versus the UK protocol. So whether it is the ASCO guidelines, NCCN, or the European guidelines, we all know that the doublets which have a similar efficacy, most of them have a similar efficacy and safety profile, and that has always been the backbone of our treatment in advanced NSCLC. Next slide, please. So current guidelines on neoadjuvant and adjuvant chemotherapy depend on the disease stage and the findings during the surgery. So in stage 1A, mostly surgery is the treatment of choice, and there is no proven benefit of neoadjuvant or adjuvant chemotherapy. But when it comes to 1B or 2A, and especially when there is the tumor size is more than 4, we mandatorily need a multidisciplinary team to discuss whether observation is an option or at all or not, or we need to give adjuvant chemotherapy. And now the role of adjuvant chemotherapy has come up with 1B, which was and the stages have also been revised as per 8th AGCC edition. So there is a question between observation and adjuvant chemotherapy for high-risk patients, and there is no proven benefit for neoadjuvant chemotherapy. So when it is stage 2B, the adjuvant chemotherapy is recommended, and there is no proven benefit of neoadjuvant chemotherapy. And when it is stage 3A, 3B, we all know that it is neoadjuvant chemotherapy or adjuvant chemotherapy or sequential therapy plus radiotherapy in N2 disease. Next slide, please. So the latest ESMO guidelines recommend that adjuvant therapy can be considered in patients with resected 1B disease, where the primary tumor, pathological tumor size is more than 4 centimeters, because there is a clear evidence of benefit with the role of adjuvant chemotherapy. However, when these guidelines were published, 1B tumor more than 4 centimeters, they have been reclassified as stage 2, as discussed in the 8th edition of TNS staging. Therefore, adjuvant chemotherapy remains the standard of choice in these patients. And in the stage 1B, as per the 8th edition of the AJCCT and staging, who are at high risk due to factors other than the tumor size. Next slide, please. So chemotherapy with or without adjuvant radiotherapy is the standard of care after complete resection in a stage 3 non-small cell lung cancer. So for the patients with stage 3 disease, the medical oncologist should work closely with the radiation oncologist and a radiologist to use a coherent approach. That is, a multidisciplinary team is always the necessity when we have these kind of patients. And as we have already discussed, the adjuvant treatment in stage 1A, it's observation. 1B, 2A is a multidisciplinary team for observation versus chemo. 2B, chemo, and 3A, 3B, chemo or sequential radiation. And here lies the importance of the patient's performance status, which is a very, very important criteria in guiding the treatment strategy for these patients. And because not all patients, fortunately or unfortunately, will complete their prescribed course of chemotherapy also at times. Next slide, please. So the LACE meta-analysis which has clearly shown an overall survival benefit from postoperative cisplatin in early stage NSCLC. It's a pooled analysis of 5 trials evaluating adjuvant cisplatin-based chemotherapy amongst the huge number of patients. And we all can clearly see that, and we have always read that the chemotherapy has always led to an improvement in the overall survival with the hazard ratio of 0.89. The absolute benefit, even though it's a single digit, but this absolute benefit is really makes a difference in which is 3.9% and 5.4% at 3 years and 5 years respectively. Next slide, please. So this is the impact of adjuvant chemotherapy in early stage NSCLC. This depends upon the stage. So retrospective analysis of estimated absolute risk benefit for 100 patients treated with surgery and adjuvant chemotherapy based on reported stage-specific 5-year overall survival rates in the control arm of each trial. So as we can see here, the various trials have also shown the impact of chemotherapy in the early stage NSCLC, which has led to the consensus that we really need to consider chemotherapy in the previously 1B stage. Next slide, please. So how well does neoadjuvant therapy or induction chemotherapy work? So answer is it is about the same as adjuvant. So as we can see from this forest plot, that even though things are not very much favorable, but after all, with the overall analysis for 1B and up 3A, the neoadjuvant chemotherapy has given a significant benefit with a hazard ratio of 0.87, and for the adjuvant chemo it is 0.89. Next slide, please. So how has the paradigm changed? So now we have come up with various other therapies that Sir previous has already enlightened us the role of especially the targeted therapy that has made a difference. And other than that, there are other kinds of treatment strategies that have come up, especially the role of antibody drug conjugates. And as we all know that the antibody here specifically targets the antigen on that particular cancer cell, and it gets internalized, and there is a payload release and a bystander effect that mostly selectively kills the cancer cell. And here we get the advantage of a selective cytotoxicity of the tumor cells. So next slide, please. So this is as we can see, the payload mechanism, it enhances toxicity, although variable drug antibody ratio affects its efficacy and clearance, but we have already been seeing whether it is the TDM1 or the recently even in advanced cases of breast cancer, that is trastuzumab deruxtecan, if I'm spelling it right, has brought again a very big change in the in fact a step forward in the treatment and management of second line, third line, and other multiple line treatment for metastatic breast cancer patients. Next slide, please. Yeah, again, so here we can see that for the TDXT, deruxtecan for HER2 mutated NSCLC cohort as well in the Destiny Lung 01 responses are also as good as 26 patients, that is 61.9% patients had a confirmed overall response rate, which was the primary endpoint. And here again we can reiterate the fact that the targeted therapy, the importance of immunohistochemistry and the tumor biology gives us a lot more, so that we can go ahead a step forward in the treatment strategies. Next slide, please. Next slide, please. So again, coming back to the standard treatment, that is the NCCN guidelines 2022. So we all mostly follow the kind of the regimen. In fact, in case of neoadjuvant systemic therapy has come up in the recent years, where we have also added immunotherapy, that is nivolumab, along with platinum doublet chemotherapy every 3 weekly up for 3 cycles. Other than that, the standard platinum doublet chemotherapies that we follow is the AUC 5 carboplatin with paclitaxel, or the standard for adenos, we follow pemetrexed based chemotherapy, and for the squamous, the gemcitabine based chemotherapy. Next slide, please. And these are the various regimens that we practice in our day-to-day clinical practice. Immunotherapy being obviously financially toxic, and the role of adjuvant therapy. Again, another data that has come up for osimertinib is, though it's a very big time duration that they have added for adjuvant treatment, where we have metastatic treatment for using IOs as 1 year. Here they have come up with adjuvant osimertinib for 3 years. But again, that is with a good data, which can give us food for thought in the recent times to come. So next slide, please. So these are again the concurrent chemoradiation regimens. We all know patients present to us in the early stage, and the most common stage that we get in our clinical practice is the locally advanced or the metastatic stage. And the mostly early we used to practice cisplatin based chemotherapy, but after weekly pacli carbo is very is now a very a good it's a good regimen that we always can afford, and the patient also tolerate well, and the response is also good. So along with other chemotherapy, we also have these regimens for concurrent chemoradiation protocol. Next slide, please. And yes, coming on to the role of durvalumab maintenance for another year, that is also the Pacific trial has also got a lot of good data, and the response has also been good in these cases. So this is again another IO therapy or the update which we have been having in these years for patients who have completed their concurrent chemoradiation. Next slide, please. So novel chemotherapy regimens for advanced lung cancers, have we reached a plateau? Well, I would say the answer is still no, because we have always been evolving and moving one step ahead. And next slide, please. So chemotherapy still remains the standard of care for the majority of patients diagnosed with advanced non-small cell lung cancer. And despite with the development of novel chemotherapeutic agents like and nab-paclitaxel, pemetrexed, and well, addition of bevacizumab that we have already discussed. There are other chemotherapy, there are other therapies as well. But again, having said that, chemotherapy remains the backbone of our treatment of our patients. Next slide, please. Next slide, please. So again, coming on to the novel chemotherapy regimens with immunotherapy, the keynote 189, it's a first-line pembrolizumab with chemotherapy versus placebo and chemotherapy in stage 4 non-squamous NSCLC. Here we got something for patients who did not have any oncological driving mutations. So there also we got a very good and impressive results for patients whom we have prescribed immune checkpoint inhibitors when they did not have any other driver mutations happening. And as already discussed, the ABCP regimen, which has also got us an option for patients who have a very bad tumor biology and who have progressed with therapies like the third generation EGFR TKIs, and patients do respond well, but at the cost of various toxicities, including financial. But we have good data to back up for these particular set of patients whom we have to offer treatment, who still have a good performance status. And the Pacific trial, that is consolidation durvalumab after concurrent chemoradiation for locally advanced unresectable stage 2, where the immunotherapy was used for a year, and the results in fact is very encouraging. Next slide, please. So again, future directions in the NSCLC's novel approaches for treatment in immune refractory NSCLC. These are again the role of immune checkpoint inhibitors with the backbone of chemotherapy and other drugs like histone deacetylase inhibitors or BRAF MEK inhibitors, and various other new drugs that are evolving. And having said that, we really need to identify every time the biology when the disease progress, and with the performance status of the patient, decision needs to be taken how we can keep giving our patients a novel approach for treatment of these kind of subset of NSCLCs. Thank you. And next slide, please. Thank you so much again for giving me an opportunity today. Thank you.
Thank you, Dr. Upasana. I don't think we could have much more, comprehensive, set of slides, and the way you brought in, it covered everything, not only from chemotherapy, but from immunotherapy and the way forward. So I think if anybody has a question, they can ask. I think it was too exhaustive and everybody has learned whatever they wanted. So without wasting much time, I would request Dr. Mandal to take on the stage, and he would be delivering a talk on the role of EBUS. Dr. Mandal is a medical oncologist at HCG, and it would be amazing to listen from him and what are his perspective on the role of EBUS. So over to you, sir. I think Dr. Mandal is there.
Yeah, he's present. We can see him. I'll
Yeah.
call him up. Just 1 second.
Please call him. Yeah.
Yes, come up.
I think
Dr. Mandal, we are unable to hear you. Sorry, sir, you are not audible.
I think Utkarsh will have to help him out.
Sir, I think it would be better if you take out your lead. Means I think if you just without the earphone, if you use, I think I think I should call him. Just give me a
Yeah,
second.
can you hear me now?
Yes,
Yeah,
yes.
better.
Yeah. Please, thank you. Sorry for the technical glitch. Please, Utkarsh, please present the slide.
Oh, okay, sir.
Yes, so today my topic is mediastinal staging for the lung cancer. So thank you everybody for inviting me to give this golden opportunity to talk a little bit about this. Actually, in our Indian scenario, in our clinical practice, we hardly get very early stage lung cancer. Whether we can do the mediastinal staging and do the surgery, the number is very less. Maximum, whatever we do, as our previous speakers told, that we at least maximum bulk of the patient consists of at least stage 3 and stage 4 disease. So when the patients come in the early stage, how I will you approach? So I will give a little bit about this. Next slide, please. So to whom I should do and how I should do the mediastinal staging. That is the main motto of our talk. So next slide, please. Yeah. So suppose there is a case one, say a 50-year-old female presented with headache and chronic productive cough, and we have done some investigation. Next one. So this is the picture of the scan she presented. Next one. And she also have the lesion in the MRI of the brain. So next slide. And next we have done the lung biopsy. It shows adenocarcinoma. Next slide. Now come to case number 2. Suppose 68-year-old man presented with chronic cough, and in CT scan we have find that yes, he has the left upper lobe mass around 3.5 centimeter. Next. And there is also a sub-centimeter level 4R note is there. Next. So we have done the bronchial biopsy, and yes, the came to be adenocarcinoma. Next. Now case number 3, another patient, 45-year-old female patient with abnormal chest X-ray. We have done the CT scan, and we found what next. And it was negative. There is no mediastinal lymphadenopathy visible on PET CT scan, but lung biopsy showed it was a adenocarcinoma. Next slide, please. So mediastinal staging in these 3 scenario what I have presented, where will we go for the mediastinal staging? So next. So first case not required. Nextly, Yes, in second case, it is the idiot candidates. We will do for US guided TBNA. Next. And case 3 also is not required. Next. So this is actually the basic TNM classification and also the overall survival. As we know that N0 consists of the stage 1, stage 2A and stage 3, and all the M1 are consist of stage 4 grossly, whereas N1 consists of mainly 2B and 3A, N2 consists of 3A and 3B, and N3 consists of 3B and 3C. And also the stage 4 has been divided into M1A, M1B, and M1C. And if you see that 5-year survival, we can grossly divide in stage 1, it falls around 70 to 90%. Stage 2, it is around 60%. Stage 3, it is around 25 to 30%. And stage 4, it is 10%. Although stage 3 is really near to stage 4. So apart from stage B, the prognosis is really detrimental. Next. So this is the overall staging and management as the guideline says that if there is a no enlarged lymph node is there and there is a peripheral tumor, so the guideline says that the invasive lymph node is not required if the PET CT scan is negative on the PET CT scan, and we can directly go for surgery and followed by adjuvant therapy. If there is a no enlarged N2 lymph node but central tumor is there and highland lymph nodes are visible, and if there is a enlarged discrete N2 lymph nodes are there, then we can divide the patient into the nodal category like N0, N1, N2, and N3. If it is a N0, N1, we can also offer him surgery followed by adjuvant therapy. And if the N2, then we have to judge it whether it is potentially resectable or not. And we have to do the tumor mode beating, where if it is we will decide that yes, a surgical multimodality treatment, if it is feasible, then we can go for it. Otherwise, we will go for the non-surgical management. And N3, there is no option for surgery. We'll go for the non-surgical multimodality treatment. And the third stage, where there is extensive mediastinal N2 infiltration and there is no need of invasive mediastinal staging, as it is unacceptable N2, and we also go for a non-surgical techniques. Next. So this is actually overall the staging patterns or the mediastinal staging, where you can see that it has been divided into the supraclavicular zone, the supramediastinal nodes, aortic nodes, inferior-mediastinal nodes, and N1 nodes. So supramediastinal groups, it is divided into the station, that is 2R, 2L, upper paratracheal groups, and 3 is divided into A and B prevascular retrotracheal group. 4 is divided into lower paratracheal group. Aortic nodes, the aortic zone is divided into station 5 and 6, subaortic and para-aortic. The inferior mediastinal are divided into the level 7, that is the station 7, that is the subcarinal. 8 is the paraesophageal. 9 is the pulmonary ligament. And N1 nodes, that is the hilar, lower segmental and subsegmental. So total 14 stations are there. Next slide, please. So this is the little bit gross idea. When will you classify? When will patient come to our OPD? How will you judge the patient and stratify the patient? As I have shown the slide, that according to the nodal staging, the differentiation of the management and the next step will be very important. So it is our job to first stratify the patient according to the nodal region. So first N1, as I have already shown, that is basically hilar and peribronchial groups, intra-pulmonary nodes. N2 is the ipsilateral mediastinal of subcarinal. N3 is the contralateral mediastinal, contralateral hilar, or ipsilateral contralateral supraclavicular and splenicular lymph nodes. Next slide, please. So now mediastinal staging, if there is a modality at 3, first one is imaging, whether we will first identify a doubt, and after that we have the endoscopic method and surgical method. So we'll come step by step. Now next slide, please. So ideal test will be the tissue diagnosis, as we will know that although we know that if there is a very eloquent area where we cannot introduce our needle, then we have to go for the liquid biopsy, especially in the molecular or molecular marker studies. But as you know, the liquid biopsy has very false negative result. But as for primary diagnosis, always preferable with the tissue diagnosis, where is the high accuracy, safety, and the low cost. Next. So in imaging, we can divide into the CT scan and PET CT scan. Next. Endoscopy will be conventional TBNA, EVAS guided TBNA, or US guided FNA. Next. And surgical method, that is the invasive procedure, that is divided into mediastinoscopy, VATS, BAMLA, and TEMLA, anterior mediastinoscopy. Next. So first come to the imaging part. Next. So now CT scan, the absence of the visualized mediastinal lymph nodes or the presence of the non-pathologic size lymph nodes, or the less than 1 centimeter or short axis diameter can be not visualized properly. Next. Whereas PET CT scan, there is no hypermetabolically activities if the uptake is less than 2.5, and it is less sensitive for the less than 1 centimeter node. Next. So this is the approximate sensitivity specificity of the two modality. CT scan, if it is the 1 centimeter mediastinal lymph node, sensitivity is 51%, specificity is 86%, and PET CT scan sensitivity is 74 and specificity 85. Next. So if we do the only CT scan, if the size, that then the size will preferred. If it is a 10 to 15 mm, then chance of malignancy is 29%. More than 15 mm, chance of malignancy is 60%. Whereas PET CT combinedly, where the 10 to 15 mm malignancy chance is 5%, PET CT scan negative, PET negative, and CT if it is more than 15 mm PET negative, then it is a malignancy chances 21%. Next. So PET CT scan, yes, there is a false negative result is around 13 to 25%. Next. Next slide. So we have to keep in mind these suspected N1 nodes, discrete mediastinal lymphadenopathy on CT scan. Tumor is more than 3 centimeters central location. Central location means we have to actually divide the whole hemithorax into 3 parts, right? So the proximal 1/3 will be the central tumor if the tumor falls into this part. Negative PET CT if in case of in low SUV uptake in primary tumor, and consider for SBRT. Next. Now, if we consider the endoscopic surgical point, the invasive mediastinal staging, then we go by like this. Next slide. So basically, why EBAS or EUS is prepared? Because yes, it is had some limitation of conventional TBNA, sensitivity 78%, and false negative rate is 28%. But it is actually real-time imaging. It is a OPD procedure, and no general anesthesia, no scar. A patient can come and go the same day in your clinic. No need to stop for the any aspirin or the blood thinners, and it is fast and safe. Next. So there are some studies that is actually showing that EVAS guided TBNA, if you do, now sensitivity varies from 92% to 95%. So it is around good number of sensitivity, and specificity is around 100%. So accuracy is varies from study to study, but most of the studies prove that it is around 94 to 97% accuracy. Next. So what are the factors may affect the diagnostic yield? It may be selective sampling, micrometastasis, especially very small nodes less than 5 mm, inaccessible nodes. Yes, another is the driver operability. That is the also important part. Next. So mediastinal staging, if we categorize into three parts. So EVAS TVNA, what are the stations? Station 2, 3, 4R, 4L. That mediastinal staging picture I have already shown. And station 7 and station 10, 11, and 12. Whereas use guided FNA, we will consider the station 4L, 5, 7, 8, and 9. Whereas the mediastinoscopy, we can go a little bit inside and we can find out the station 2, 3, and 10, 7 and 5 and 6. Next. Now there is a thought that why the combination of the ultrasound guide, ultrasonography, CUS, and we can consider is the EVAS and EVAS, because the EVAS part where the lung tumor and the 2R and 4R and 4L and 2L, that's the paratracheal group of lymph nodes are easily accessible by both of this technique. Now, EVAS had some advantage of this in one group of lymph nodes, 10 as a level station 10, 11, and 12, whereas that US has the advantage of getting that the station 8, 9, or have the left adrenal lymph metastatic lesion or lymph nodes accessible or any liver metastasis. So if we combine these two procedures, that must be importantly enlightening the diagnostic capability. Next. So if we consider the combined ultrasound, then we can see that sensitivity of the in different the four trials that has been shown, that it varies from 73 to 91 to 96. But yes, all that maximum trial showed there is a more than 90% sensitivity, and negative predictive value is also higher for this if you consider the two combination of the two procedures. Next. So same things, it is a forest plot showing the different studies, the combining effect, where it has been proved that yes, sensitivity is grossly 87% and specificity is around 99%. So it is a very good number of data it is showing by combining these both ultrasound techniques. Next. So what are the cons? Cons will be like positive USFNA in lymph node, which could be assessed by EVAS guided TBNA, and station 8 and 9, where there no difference in the diagnostic yield by USFNA, and low prevalence of lymph node station in 8, 9 metastasis. Next. So false negative results, although false negative results are low, TBNA conventional is a 28%, where the EVAS guided and US guided is around 19 and 20, almost similar. Now, if we have the negative results from the EVAS or US, then what to do for the next? Next. So then we have to go for the surgical invasive procedure. As I have told that there are 5 techniques, mediastinoscopy, where we can address the lymph node station 2, 4, 7, 10, where the specificity is 100%, sensitivity is 89%. Anterior mediastinoscopy, where we can, apart from this, we can added value of this station 5 and 6, that is easily approachable by the anterior mediastinoscopy method. But here the specificity is little bit less, 91%, sensitivity is also less, 78%. And extended cervical mediastinoscopy, where the sensitivity is 70 to 80%, but not reach the specificity, and VAMLA, where the same stations, where the sensitivity is a little bit higher, 96%, specificity is 100%, and TEMLA, where the other groups of lymph node can be taken care of other stations, but where the specificity is not available. Next. So if we combine this EVAS guided TBNA and mediastinoscopy, then sensitivity is like that EVAS like 89%, only mediastinoscopy 68%, and yeah, in other trials is shown is almost more than 80%, and meta-analysis show yes, sensitivity is 84%, mediastinus 86%. There is not much different, but negative predictive value, it is also comparable in one study. Another study, it is showing that around 85% in negative predictive value for EVAS and mediastinus is 79%. Next slide. So as you have seen that both techniques have the similar performance in mediastinal lymph node staging in lung cancer. Next. So population with high prevalence with mediastinal mediastinal lymph node metastasis, where we can combine this, and if the combined ultrasound is negative, then definitely we have the approach for the mediastinoscopy as at a higher sensitivity than the mediastinal alone if we combine this, and p-value is also significant. And add this mediastinoscopy to the combined ultrasound increase the sensitivity in the negative predictive value by 9% and 11%. Next. So invasive mediastinal staging, our goal to avoid the surgery on positive N2 disease where the tumor is more than 3 centimeters, central tumor, N1 or discrete mediastinal lymphnopathy, N1 or N2 lymph node that was positive in PET CT scan or negative PET CT scan, low SUV uptake in primary tumor, and it is not required for the clinical N1, N0 with peripheral tumor. Next. So suppose EVAS scattered TBNA we have done as I have discussed in case 2 and it's negative. Next, what to do? Next slide. So yes, if it is negative, as we have told, that mediastinoscopy will be suggested. Next. Next slide. So these are the actually the recommendation from the different guideline. So suppose peripheral 1A lesion is T1A, B, C, N0, then ACCP guideline says there is a not required. ESTS guideline says also not required. NCCN 2017, according to 2017, it is said it is optional. And if it is a central lymph node 1A, 1B, stage 2, yes, ACCP guidelines tell that suspicious N2, N3 with central T for N1 nodes agar positive, and then we can do, or ESTS the central lesions or suspicious N1, and NCCN guideline definitely recommend this. And if it is a stage 3, ESTS and NCCN both recommend of this mediastinal staging. And other recommendation is like that needle technique is suggested in ACCP and high suspicious but negative results using the needle technique followed by surgical technique. And NCCN guidelines told that least invasive biopsy is preferred. Evaluation of the subcarinal and contralateral lymph node is important even when employing the EVAS or EUS guided approach. Next slide. So now this is the step. So suppose a patient came with your imaging in your clinic, CT scan and PET CT scan we have done, and it is showing that mediastinal lymph node is negative. Then next step, next. So if the clinically it is N0, a peripheral tumor less than 3 centimeter, I will suggest for go for the surgery. Next. Now suppose patient, if you find that yes, clinically N1 and central tumor size is more than 3 centimeter, and then tissue confirmation done by the EVAS or the invasive mediastinoscopy, and if it is the mediastinal lymph node is negative, then we can go for surgery. So before surgery, we have to keep in mind that we have to definitely do the tissue confirmation by EVAS or invasive technique to confirm that what is the nodal status. Next. So mediastinal lymph node positive, then tissue is definitely we have to confirm it. And if it is the mediastinal lymph node is positive, both by imaging and by tissue confirmation, then definitely we have to go for the multimodality treatment. Next. And if the PET CT scan showed that is a mediastinal lymph node positive, but on tissue confirmation the mediastinal lymph node is negative, then we have to don't leave the patient. We have to do the invasive mediastinoscopy. Then we have to see whether the mediastinal lymph node is positive. Then definitely we have to go for multimodality treatment. Next. Or if the mediastinal lymph node is negative, then we are confirming yes, then we can go for the surgery. Next. So to conclusion, the imaging, the sensitivity of the various procedures appears to be similar. Next. And endoscopy availability, experience, skill, location of the suspicious nodes, patient factors, these all to be considered before approaching to the any invasive procedures. Next. Thank you.
Wonderful, Dr. Mandal. I should compliment you for a topic which I think as a medical oncologist, we generally do not go into that detail, but you have made it, clear, and there's ultimate presentations. And I think most of us would be very clear if required, if we have a case where we have an early stage lung cancer, so how to go about it. So if there are any questions, I think Dr. Mandal would be more than happy to answer those. I think there are none, because most of us, I think, really are very awed by your presentation, and I think most of the things are very clear to us. So we move ahead, and I would request Dr. Srujana to please come and deliver her talk, which is on the newer paradigm in resected EGFR mutated early lung cancer. So I believe she would be speaking on more of the adjuvant trials in EGFR mutated lung cancers. So welcome, ma'am. We are very eager to listen to your talk.
Thank you, Abhishek sir, for having me here. Can I have the slides?
Just give us a minute.
Yes. So, a very good evening to one and all. My topic would be the newer paradigms in the treatment of resected EGFR mutant early lung cancer. Next slide, please. So, most of the lung cancer deaths occur around the world, and it is one of the most common causes of cancer-related deaths worldwide, along with the breast, prostate, and colorectal cancer combined. And as we all know, non-small cell lung cancers accounts for 85% of all the lung cancer cases. And out of these patients, only very few are present with resectable disease, that is approximately 30%. Next slide, please. So, despite being surgery the primary modality of treatment in early stage NSCLC, and then followed by the adjuvant cisplatin-based chemotherapy in stage 2, 3A, in selected patients with stage 1B, that is more than 4 centimeters tumor size. A LACE meta-analysis which has been done addressing the benefit of the adjuvant chemotherapy after surgery. The 5-year overall survival benefit, absolute benefit, is just around 4 to 5%, with a very marginally low hazard ratio of just 0.89, accounting for 11% of reduction in death of cancer-related cases, lung cancer-related cases, and the disease-free survival hazard ratio is 0.84. So the disease recurrence or death occurring after surgery and then adjuvant chemotherapy approximately increases by around 20 to 30% as we go across the stage 1, 2, and 3. As we can see from the figure here, stage 1B, the 5-year recurrence rates are 45%, and stage 2, the recurrence rates are 62%, whereas in stage 3, as high as 76% cases recur despite the surgery and adjuvant chemotherapy. Next slide, please. Next slide. Next. Next slide, please. So, because there are high recurrence rates despite the local therapy and then the adjuvant chemotherapy, there is an unmet need to address this population for improving the survival, disease-free survival, and the overall survival rates. So, as we can extrapolate from the EGFR mutant population in the advanced or metastatic setting with improved survival rates with the targeted tyrosine kinase inhibitors, like the first, second, and third generation inhibitors, with marked improvement in the PFS as well as the OS benefit. So they have started searching for the mutant or any targetable mutations so that we can target them and then we can improve the survival for these patients. So in that way, adjuvant osimertinib has been tried. And the ADAURA trial has been designed with this background, which is a phase 3 double-blinded study designed in stage 1B to 3A patients who have been resected and who have received or not the adjuvant chemotherapy. They have been taken into consideration and stratified according to the EGFR mutation status, the stage, and the race, Asian versus non-Asian. Into the osimertinib, they were randomized into the osimertinib and versus the placebo arm in 1:1 ratio. And osimertinib was given in the dose of 80 mg once daily for 3 years or until disease recurrence or progression. So the primary endpoint was DFS by investigator assessment and secondary endpoint was DFS in the overall population. Next slide, please. So broadly, the inclusion criteria have been discussed in the previous slide. The exclusion criteria needs to be mentioned in those patients who have received prior radiotherapy or chemotherapy or who have received EGFR TKIs. And if the time duration is more important in this trial, if in patients who have not received any chemotherapy, the time for randomization is within 10 weeks of surgery. And if those who have received H1 chemo, it is 26 weeks within the randomization, within the completion of surgery. And those who had only segmentectomies or wedge resections were excluded. That mentioned the patients who are having lobectomies with or without segmentectomies were included in this trial, and those who had only the wedge resections and segmentectomies were excluded. And any patients having the baseline ILDs and QTC prolongations and any contraindications of cardiac related factors were excluded. Next slide, please. So the baseline characteristics were well balanced between both the groups, be it in the age, gender, smoking status, or the histology, and the EGFR mutation status. And the most common mutations that exon 19 deletion and L858 are mutations only were taken into consideration in this trial, which account for 90% of the EGFR mutations. And 60% of patients have received adjuvant chemotherapy in both the arms. Next slide, please. So as we can see, the primary endpoint DFS has been met in this Kaplan-Meier curve with a hazard ratio of 0.17 in stage 2-3A population. The median DFS is not reached versus 19.6 months in the placebo arm. Whereas in the overall population, that including stage 1B, 2, 3A patients, the hazard ratio is 0.2. That is 80% reduction in the deaths in overall stages of resected lung cancer. Next slide, please. And especially in stage 2-3A, there is 83% reduction in the risk of disease recurrence with the use of osimertinib. Next slide. So the 2-year DFS percentage wise, it has been maintained across all the age groups, stage 1B, 2, 3A. It has been around 88 to 91%, and the hazard ratio is quite significant, and larger benefit is seen in stage 3A patients, where most of our patients present in advanced stages. Next slide, please. And this is the forest plot showing benefit across all the subgroups, irrespective of whether the patient received adjuvant chemo or not, the type of mutation, EGFR mutation, irrespective of the EGFR mutation status, the patient is getting benefited, and across all stages, Asian and whether patient is Asian or non-Asian, irrespective of the smoking status. And the larger benefit is seen in the smokers, surprisingly. So this is about the DFS, and next the secondary endpoint, that is the overall survival. When they have seen the median OS is still not reached, and almost both the curves are matching to the tune of 100% in osimertinib patients. This is similar to the breast cancer survival curves we see in hormone positive breast cancers. Next slide, please. So when we compare these results with the previous trials which have been done with the first and second generation TKIs, the lorlatinib and the gefitinib, there were mixed results. In some there were benefit, in some there is no benefit in the DFS, and there was no overall survival benefit. Here the point to be noted is that all the trials had a 2-year DFS, and then the curves started merging. But here, after 3 years also, the curves are still separated, and we have to wait for a longer follow-up data if the curves start merging like those of that of the previous TKIs. Next slide, please. So what is the added advantage of giving the third generation TKI osimertinib as compared to the first and second generations? Mainly the CNS recurrences, which the EGFR mutant population is prone to. So the most common site of distant recurrence being the CNS in this population. In the RADIANT study where erlotinib was used, 37% of recurrences in patients who have received erlotinib were the CNS recurrences. So osimertinib, as we all know from the metastatic setting, it has demonstrated a significant amount of reduction in the risk of CNS progression to the tune of 52% as compared to the first generation TKIs. And it has got a very good blood-brain barrier penetration. Next slide, please. And the type of disease recurrences also affect the survival, because the local recurrence patients do better than those patients who present with distant recurrences, where the burden of the disease is wide and it is difficult to treat these patients. Local recurrences can be addressed with the surgery or the radiation, and they have a very good survival benefit. So in the ADAURA, similarly, after giving the adjuvant chemotherapy, without adjuvant chemotherapy, and then the osimertinib, the local recurrence rates were distant recurrence rates were less, and the local recurrence rates were a lot more in either of the arms. So to see, there was only 11% of the patients having the DFS events. Out of these 11%, 38% patients were having the distant recurrences, and 62% were having the local recurrences. And out of these 38, this is in contrast to the 38% recurrences in the osimertinib, there is 61% recurrences in the placebo arm. Almost the local recurrences rates were halved with the osimertinib arm, whereas the distant recurrence rates have been doubled in the osimertinib arm. Next slide, please. So as we can see, the CNS recurrence rates were less in the osimertinib. Just 1% of the population have developed CNS as compared to the 10% in the placebo arm. Next slide. So this is the same slide depicting that only 1% of the patients developing the CNS DFS events as compared to the 10% population in the placebo arm. Next slide, please. So when doing a sub-analysis, we have seen that in the overall population, there is DFS benefit with a hazard ratio of 0.17 to 0.20. The same is extrapolated in the CNS related DFS in the overall population with a hazard ratio of 0.18. The 4-year survival accounting to 98% versus 82%. Next slide, please. So majority, there were no major side effects as seen with the like that seen in the first generation TKIs. The rash is a little lesser, and the grade 3 events were also lesser in osimertinib. Next slide, please. So the most common side effect was the diarrhea and the dry skin and all these. Apart from that, we know that it can cause QTC prolongation, which is seen in 7% of patients as compared to 1% patients in the placebo arm. And grade 1 or 2 interstitial lung diseases is reported in 3% of the patients. Next slide, please. So again, there was an analysis done in this trial based upon whether the outcomes differed between the patients who have received adjuvant chemo and versus those who did not receive adjuvant chemo. Next slide, please. So as we know, as the stage is higher, the majority of patients will be requiring chemotherapy. 3 patients, around 80% of patients have received adjuvant chemotherapy in this trial. Next slide, please. So in the overall population, in patients who received adjuvant chemotherapy, the maximum benefit is there because they are the patients who are having poorer prognosis and higher chances of developing recurrence. Around 89% versus 49% DFS rates were observed, almost double the DFS. Whereas in those without adjuvant chemotherapy, 89 versus 58%, a 30% benefit is seen. Next slide, please. So across all the stage groups, whether the patient received or did not receive chemotherapy, the benefit is seen with osimertinib as compared to the placebo. Next slide, please. So this is all the Kaplan-Meier curves showing the same things as mentioned, that it is the benefit is seen across all the subgroups, be it stage 1, 2, or 3. In patients without adjuvant chemotherapy, the benefit is seen in stage 1B because these are the patients who do not require usually the chemotherapy except for the higher risk patients with more than 4 centimeter grade tumors. Next slide. Whereas in the stage 2, the benefit magnitude of benefit is higher in those who received adjuvant chemotherapy as compared to those with adjuvant. The osimertinib arm, the median DFS is still not reached versus 29.4 months in stage 2. Next slide, please. Whereas in stage 3A, the osimertinib achieved 38.8 months as compared to 12.9 months of DFS in the placebo arm. It's almost the survival, the disease-free survival is almost equal to that of the stage 1 and 2 patients. Next slide, please. So as an medical oncologist, all the endpoints of the trials, the true endpoints, we all know that it is only the survival or the quality of life which matters. So the patient-reported outcomes from this ADAURA trial, how far the patient can tolerate the osimertinib, whether is there any deterioration in the quality of life of the patient, has also been studied by Margarita Magem et al. Next slide. So they have taken SF36 scale for assessing this health-related quality of life. In this, there were 2 components, the physical health and the mental health components, and it is the score is a sum of these 2 components, which are assessed in 8 health domains. And the data has been collected right from the time of the surgery, and then after surgery, then randomization, then till the patient is under follow-up for 3 years, or the patient has recurred or progressed. Next slide. So compliance has been very good in both the arms. The patients were able to comply to this SF36 health survey in both the arms equally. Next slide, please. So time to deterioration of the physical and mental components, to summarize, during the disease-free period, the majority of patients did not experience a clinically meaningful deterioration in either of the components. Next slide, please. So, in conclusion, adjuvant osimertinib is the first targeted agent to be showing a statistically significant and clinically meaningful improvement in the DFS in stage 1B to 3A EGFR mutant population and SCLC adenocarcinomas. And 80% reduction in the risk of disease recurrence is a very huge benefit for this poor subgroup patients in the disease recurrence or the death, with a hazard ratio of 0.20. And the 2-year DFS rates being 89 versus 52%. And overall, the best point is that there is a clinically meaningful improvement in the CNS DFS also, as compared to the placebo. And it is also safer to use with milder EGFR related toxicity effects like skin rash, diarrhea, and these things. And the median duration of osimertinib exposure being 22 months. Next slide. So the benefit persisted even in patients who, irrespective of the status of receiving chemotherapy, and the higher disease recurrence rate rates were observed among patients in the placebo arm who received adjuvant chemotherapy as compared to those who didn't, which is a prognostic factor for disease outcome. Overall, the health-related quality of life was maintained in the adjuvant osimertinib treatment arm. It is a highly effective and practice-changing therapy for this stage 1B to 3A receptor EGFR mutant population after complete resection of the tumor. Next slide, please. Yes. Okay. Thank you.
Thank you, Dr. Sujana, for a wonderful presentation. I just have one question. Like, have you been lucky enough to give any of your patients this drug?
No, sir. Adjuvant osimertinib, no.
Okay, so yes, because you have to be twice lucky, you know. First of all, you should get a patient who has been resected and he should be GFR positive. So yeah, same here. I have no such experience, never been so lucky, but wonderful presentation. And you have set the ball rolling for osimertinib, and definitely there is a lot of advantage of osimertinib we have seen. So now we'll go to this panel discussion, and if you're around, Dr. Sujana, we'll be happy if you can also chip in. This is going to be a very informal discussion, and I think they have very pertinent questions. I was very happy with the slides that they have made, and it's very something which we keep thinking. So it would be very good. Like, I think we have Dr. Shiva. Are you there? I think Dr. Mandal, I hope he is there. Dr. Ashutosh Daga, if you are there. And I would be very happy if Dr. Abhishek Anand or Dr. Shyamala, everybody could just join in for this, very informal discussion as to, how things and what are we supposed to do in certain scenarios. So if I can share my slide. I'll share my slide. Don't worry. If you just allow me, to share my slide. Okay. So is Dr. Swami there? No, I think Dr. Mandal, you are there?
Yes, I am here. Thank
Very
you.
good. And Dr. Upasna is also there. I could see her. Yes.
Yes, sir. Yes, I am there. Thank you, sir.
Dr. Ashutosh Daga is around. Yeah, I think he's also around.
Hi, sir. Good evening.
Hi, how are you?
I'm fine, sir.
Very great. Yeah, no, I'm just willing to listen to all of you, and learn something new out here. So they have given me, I think this is a good slide set. And so definitely it is on EGFR. And three basic questions which they have come across with is, what are we supposed to do if we have EGFR mutated with high PDL1? And second is, if you have an EGFR mutated and you tend to progress. And then we would discuss if you have an oligo progression or maybe something more than that. And what are we supposed to do if patients has brain metastasis? So these are the basic three questions on which we will be discussing. So first case which has been given is a 64-year-old male patient, non-smoker, pleuritic chest pain, had a left lower lobe mass of 5.5 centimeter invading the pleura. There were few lymph nodes, and there is also pleural thickening and effusion. So it has been diagnosed as stage 4 CA lung adenocarcinoma, PDL1 expression 95%, and oncogenic driver EGFR, I think del 19 is there. Very good. So with this, just give me a moment. Yeah, okay. So, Dr. Ashutosh, whenever a new patient comes to you, do you at the first go send all the molecular markers, or how is it at your center?
So basically, sir, we see the stage first.
Okay.
It's not a metastatic disease, I usually don't send any markers.
Okay, then Dr. Sujna
because
would be happy with you. she would be very happy. She wanted to give osimertinib also in adjuvant setting, so you don't send it in.
I am not very much convinced. I am not very much convinced with the osimertinib data of adjuvant, sir.
Okay, chalo, we'll discuss it some other time. Okay, so now we'll discuss with a metastatic setting. Okay,
Yeah.
yeah. So please go ahead.
Yes, I usually don't send all the markers till I get the stage. Yeah, definitely. If it's a stage 4 disease, I think rather than doing all the panel, because maximum of patients cannot afford that kind of drugs, at least simple markers like EGFR L cross will do for me.
Okay, and
along with PDL1.
And also PDL1.
So yeah.
So do you sequence it, or you straight away send it at the first go?
So comes with a stage 4 disease, then I'll send it at the one go only.
One go, okay. And no, very, very true. And what about Dr. Sujna? Like, what is at your center?
Sir, if it is a stage 4 disease, we have an in-house smart lung panel for our patients, which covers EGFR, Alcross, and all the 7 mutations which have the drugs approved. At least we can know the molecular profile of the disease, and it comes quite faster in 15 days. Meanwhile, we'll give a short dose of chemotherapy till then, and then wait for the report.
Okay. So this brings us to the next question. What is your plan? Like, how many cycles of chemotherapy? You said that you might get it in 7 to 10 days. So how do you do it?
We give a weekly dose of chemotherapy, sir.
Okay. And then you stop when?
Then we stop, and then if the target has come, then we start it.
Okay. So generally, probably at best, you would be giving 2 cycles of weekly chemotherapy. Okay. And Dr. Upasna, what's your center?
Sir, the reports actually take a procedural delay to come. So I start the chemotherapy and follow up with the reports. And if they are available, mostly our patients, they tend to complete 4 to 6 cycles by that time. 4 cycles get completed by the time I get the reports.
Okay. Rajiv Gandhi Center, they're very well off, so they can get it very fast. Okay. So the second question is, I think, similar one. How soon do you get PDL1 IHC report vis-a-vis EGFR/NGS report in your institution? So I think more or less we do For poor people like us, I think it takes 7 to 10 days, but in better centers, we get it earlier. Okay. So would you wait for EGFR report if PDL1 IHC is high? Dr. Sujna, what's your take?
Yes, sir. Yes, sir. We wait for the EGFR ALK report.
Okay.
Because
Anybody differs with it? Like, or do we all do that? Dr.
I
Ashutosh?
think if somebody is a heavy smoker, I will be intended to give PDL1 if somebody can afford.
Okay. Okay. So like
I've done in 1 or 2 of my patients, and they have turned out to be EGFR negative. I got the PDL1 and we started on immunotherapy. And I think by the first cycle only you will get the response. So that gives a confidence that, okay, we're going in the right direction.
but suppose if you give it in the first cycle, chemo IU combination, and we are very happy to get a response, would we feel that it's because of the IU, or it would be more because of the cytotoxic chemotherapy?
Yeah. So it can be a fact of both, sir. But usually with only 1 cycle of chemotherapy, lung cancer patients will not have a very much dramatic response. The dramatic response only comes when you have a IO or a EGFR TKI, which is carrying forward the response and the by disease biology.
Okay, what's your take, Dr. Sujana, on this point? Like the urgent response would be more because of IO or because of cytotoxic chemotherapy? Just an
it would be because of chemotherapy, sir. IO will take time.
Okay, no, it's okay, but like it's a very evolving field, and I feel the more we discuss among ourselves, I think something new comes up. So if a patient is symptomatic and PDL1 is high, EGFR. Oh, Dr. Mandal.
I'll just share one of my examples, sir. PDL1 80%, only brain mets, and the patient was I'll say PS4.
Okay.
And with 1 cycle of Keytruda, from the next cycle, the patient was coming walking in my clinic. So it's a very vague field. It's a very I'll say the spectrum is not like that. You can say that the immunotherapy does not work very fast. It depends on biology of the disease also.
Yeah, I think there are a lot of things, and you are very true. We cannot be very pragmatic in our approach or be in the tight compartmentalized way, and things are very evolving. There could be people who could just say that probably somebody would have given steroids which would have worked on this patient, for brain met. So you can discuss it either ways, but I think we should be open to all these scenarios, and it's always a learning for all of us. So Dr. Mandal, just input from you for the last question. If patient is symptomatic and PDL1 is high, EGFR is awaited, how do you treat such patients? Like, I think the same question.
Yeah, sir. Basically, if the patient is symptomatic, definitely in metastatic disease, basically we have to see the volume of the disease, right? So if the volume of disease is high, there is a high volume of disease, definitely we will I have to start some form of systemic therapy in form of chemotherapy. And definitely I will wait for the EGFR to be awaited.
Okay. No, yeah, that's very true. If he's symptomatic, I think all of us would try to give him, if not chemo IO, at least chemo will definitely give to this patient. Okay. So this is a good slide I can just show you. So if you have an EGFR mutated and you also have PDL1, these are the 2 strong markers. So which one should be prioritized? So Dr. Ashutosh, like it's the same question being put across in a different manner. So which one would you prioritize?
So you are talking about, sir, during the time of testing or after getting the results?
Suppose patient comes to you with both the reports, with PDL1 of, let's not take it 90%, let's keep it at maybe 20%, okay? And EGFR del 19, or whatever spectrum that you want. So, like, how will you?
Obviously, if there is a driver mutation, then the PDL1 takes the back seat.
Okay, so anybody having any different point on this? I don't think so. Everybody will be more than willing to give if we have an upfront driver mutation. So this was outcomes in EGFR mutated NCLC therapy. If you're giving anti-PD-L1, and similarly, so the two spectrums, but I think all of us would, and the little understanding which we have of these drugs are that you give EGFR inhibitor first, and then maybe on progression, you can think about addition of PD-L1 with the caveats that if you don't want him to have more of pneumonitis and ILD and those kind of things, but we all would agree that EGFR inhibitor should be given upfront. So even the data which has been, subgroup analysis from FLORA trial, they have all shown that whether you have a very high PD-L1 or low PD-L1, or even if it's unknown, if you have an EGFR mutated patient, probably giving an anti-EGFR therapy makes sense. And similarly, we have different kind of immunotherapy being used, but never we have seen that we have more of an OS advantage in case if you are using immunotherapy in EGFR inhibitors, in EGFR mutated patients. So that's the reason why even the NCC and all the guidelines say that if you have a driver mutation, then you treat accordingly. I think all of us would agree to this. So similarly, ASCO guidelines, NCCN guidelines. So everybody believes that we have to treat it that. So now we come to the second scenario. We have treated the patient with maybe osimertinib, and 14, 15 months down the line, he comes with maybe any kind of progression, maybe progression in the lung itself or some newer disease coming up. So we are not talking about oligo progression, but we are talking about good systemic progression, and the patient has now come with a progressive disease. So what would be the idea behind, how are we going to manage it? Dr. Mandal, please, your comments.
Yeah, so basically we have to first see the volume of the progression, whether it is a multiple lesion and then patient is symptomatic, or whether it is asymptomatic and localized, like oligoclonal, oligo or mono just less than 5 lesions or like that. So if the patient is asymptomatic or symptomatic with limited meds, then definitely we have to along with this targeted agent, we have to definitely address the lesion with the local therapy, any form of local therapy. But yes, if there is a very multiple lesion, huge burden of disease, and patient is severely systematic, have the burden of disease not controlled by this local therapy, definitely we have to switch it at the last point.
Okay. So this brings us to the next question, that suppose, are we planning of doing any rebiopsy? Dr. Sujna, what's your take?
Yes, sir. At our center, we advise for a rebiopsy. If the patient had taken a first generation TKI, then definitely we would look for T790M mutation, and then osimertinib can be offered to this patient. If a patient is already on osimertinib, there are some resistance mechanisms and trials going on with osimertinib plus MET inhibitor, and these things patient can fit into any trial.
So,
and whether it has been lost, the mutation has been lost, can also be tested in rare cases.
So, like in your centers, is it like practically every progression on osimertinib you do, if possible, a tissue biopsy, or do you go for any liquid biopsies also? Like,
If possible, we would do a tissue biopsy, sir, but most of the cases there will be a minimal amount of progression, so we will not be able to biopsy, and patient will not be willing in most of the cases. In that cases, we advise for a liquid biopsy.
And what has been your, experience with liquid biopsy reports?
Yes, sir, they are good. Yes.
Huh?
Even though the sensitivity is less, but we can pick up the EGFR mutations and the resistance mechanisms there.
Okay, so like what kind of mutation do you like resistance mechanism are normally picked up? Like, what's your experience?
Usually we do T790M mutation only, sir.
But like somebody who has already been given osimertinib, are you really worried about T790?
No.
No, you're not worried. So I just wanted to share the experience, like what's there, because ideally, definitely we should be doing it.
There is one trial going on with for liquid biopsy to test the type of resistance mechanism with osimertinibs.
Okay.
So,
so Dr. Ashutosh, now this patient has got extensive meds, okay, not about oligomeds. So your take on rebiopsy and what are we going to, get out of the rebiopsy? What is your, like, just wanted to share your...
Again, sir, again, sir, that one of the thing is if somebody is on the first generation TKI and if there is a rapid systemic progression, then two or three things which comes to my mind. One is obviously T790M, or what is the resistance mechanism which is going there, whether it's a meta amplification or something other which is going on. Second thing, I have seen cases even of EGFR positive who has a small cell transformation. So that is a very important thing that we should not miss it, because again that will change the whole biology of the disease. That will change the whole tempo of the disease.
In fact, I have also seen, and just to share, what was earlier told to me as an adenocarcinoma, actually it was an adenosquamous, and the next biopsy was just florid squamous. So even the histopathology, and definitely it could transform into small cell, it could transform into squamous, it could go into a large cell neuroendocrine carcinomas. So I think there's a lot of sense to doing a rebiopsy if it's a biopsyable lesion. So I think we should go ahead with that, and definitely the added advantage of, you know, what are the escape mechanisms and on target, off target, and I think very soon we'll have a lot of trials coming up, because now after I think 3 years down the line with giving osimertinib, I think now we have started picking up cases where we are seeing the failure of osimertinib. Probably in the first 2 years or so, we were not much worried and very happy with giving osimertinib. But more and more trials are coming up, like Orchard trial and all, which are looking at various, you know, different kind of mutation which might be picked up and different. So yeah, so this was a patient.
Yeah. So they are giving osimertinib in combinations with IO now, sir.
Yeah.
So I think the problem of pneumonitis, I don't think so that is too much of concern in the Western world as of now.
Correct. In fact, I will share something with you. Unfortunately, in our hospital, we never had any constraints of IO. Okay, so we already had enough, so there was never a problem. So when the onset of COVID happened, there was a lot of hue and cry whether we can give or not, you know, because we never knew that, you know, how his lung would manifest. But trust me, over the period of COVID also, I would have given IO to almost 250 to 300 people. Though we had an advantage that in our hospital, we could keep patients for 6 months, you know, there's no issue with that. So I am also yet to see any such, you know, devastating ILD or pneumonitis happening because of, you know, this IOs. But definitely post osimertinib giving IO, that experience I don't have. So that's very theoretical as of now. And as you said, there were newer trials whereas they are using geftinib plus osimertinib also. Even this is being tried with a concept that if you have 797 C797S mutation, probably it might work. You know, geftinib might work there. So definitely a lot of things happening. So like this patient had on surveillance 2 new metastatic bone lesion. So what will be the next step? I think Dr. Mandal had. We had discussed this issue of, you know, biopsy and, you know, so Dr. Mandal, how would you like to continue? I think you have already answered. If there are 2 lesions and it's local,
Yes. Yes, local therapy to be added and continue the osimertinib. There is no option for switching there right at this point. Yes.
I think all of us agree with this. Dr. Srijana, Dr. Upasana, sorry, I haven't asked you. So what's your take?
No, sir. Thank you. Like I completely agree, and it's always it is always in agreement with the discussions that my seniors have given their opinion as well, and I agree to it. So since it is already a stage 4 disease, we need to stretch the survival, maintaining the quality of life. So my decision would be the same.
Okay, you're always.
And again, biopsy. I even also had a case like it had a small cell transformation. So yes, biopsy is always the first priority. And if the patient is very symptomatic, unfortunately, I sometimes I have to start some kind of treatment, and to wait for the biopsy report also sometimes become difficult. But having said that, to be specific, I don't know whether I should be saying this or not in this platform, but ideally we need to wait for the biopsy report and then start the treatment. Thank you.
Fair. Yeah. So we'll give the local therapy and continue with the osimertinib. Okay. So now patient was treated with local stereotactic body radiotherapy for bone lesion, continued for 8 months. Now, post which patient had progression with multiple lesions. So how you come across a case of oligoprogression? I think we have discussed this thing. So we all agree that we have to treat with local ablative therapy or whichever local therapy and continue with the osimertinib. So there is enough data to help us, do that. So this approach can maximize the duration of EGFR TKI and prevent switching to some other systemic therapy. Okay, so we do agree. So there is enough abstract and publication to support our the way we are working. So even the NCCN suggests the same thing. So more or less, you're supposed to continue, give local therapy and continue with osimertinib. Okay, so now we have CNS meds. So 53-year-old patient relapsed while being on chemotherapy for stage 3A. Okay. Subsequent scans revealed pretracheal nodal hypermetabolism, and on repeat MRI scan, she was found to have multiple brain mets, including 3.1 centimeter inferior Vermean metastasis with surrounding edema. Osimertinib was started at 80 milligram daily, and patient complain of ataxia, which worsened significantly in the following days and was scheduled for craniotomy and tumor resection the following week. Okay. What will be your line of management in a patient? Symptomatic CNS metastasis. Yes, I think this requires some deliberation. So Ashutosh, Dr. Ashutosh, what will be your take? Symptomatic CNS metastasis.
So this case was a curative patient initially, and we started an osimertinib in a metastatic setting, correct?
Yeah, now when he became metastatic.
Okay, and he is EGFR positive.
Should be, yeah.
Okay, okay. So, he never got symptomatic treatment to the CNS before.
Oh, no.
And I think he's a good candidate to have some form of local therapy, either in the form of neurosurgery or in the form of local radiation, whatever it is. And I think we can, if the symptoms are resolved, then we can continue the same systemic therapy.
Okay, so okay, just to slightly get it into more perspective. Okay, 66 or whatever year old, started on osimertinib, and maybe 7-8 months down the line has now got a brain mets, which may be amenable to SBRT or even surgery, a small lesion, but is definitely symptomatic. So let's see another case, a case which comes upfront to you and comes with a brain metastasis, symptomatic brain metastasis. So how will we go about that? And the different case would be if you have already treated for 8 or 9 months of osimertinib, and now he comes to you with a symptomatic brain metastasis. How would you differentiate between these two patients? Dr. Upasana, please, can you give your ideas?
Yes, sir. So if a patient is upfront coming with a brain mets and the patient is EGFR positive, then we can already, as discussed in this particular case, so we can start on osimertinib, and obviously we can start on steroids, and then see whether it is if there is and take a neurosurgical opinion, and continue osimertinib. But if symptomatic brain mets would need local radiation, but in practical settings what we give is whole brain radiation. But if it is if it's just as if oligo if the brain mets is not very like widespread, and it is amenable to SBRT or other localized therapy, then obviously we can go for it and then continue osimertinib if the patient is upfront coming with brain mets. And now if the patient has is on osimertinib and progressed with brain mets. Again, since as of the data what we have, the blood-brain barrier penetration for osimertinib is good. So if I would continue osimertinib and give local therapy and assess the response, because I don't have much experience. For me, this is a theoretical case,
Okay,
because
fair enough. So, Dr. Sujna, what would you do in RGCI?
Sir,
Upfront
in
brain mets?
symptomatic cases, upfront brain mets, first we'll address the brain and then start osimertinib, be it local or surgery. And if on osimertinib, if there is oligoprogression in the brain, then if asymptomatic, or symptomatic, he will be given radiation to that point, SBRT. If it is frank progression, then WBRT. And
Okay, so the basic the thought process behind is that you would like to treat the brain lesion, and vis-a-vis, suppose I say that we know that osimertinib is supposed to cross blood-brain barrier, and a patient comes to me upfront with a brain mets, and I give him DEXA and steroids and all, and the symptoms, wane off, and I start osimertinib. Okay, so is there a point in waiting? Maybe giving him for 15-20 days only osimertinib and doing some, supportive treatment for brain mets rather than exposing him to any surgery or even an SBRT. So what is your take? Like, would you wait for 2 weeks and look at a symptomatic response, or upfront you would like to address the brain?
no, sir, I would like to address the brain upfront.
Fair enough. Dr. Ashutosh?
So if, sir, it's very close to a very important structure like a midbrain, or is it compressing some ventricular system, then definitely I will tempted to give radiation upfront.
Okay.
But if it's a solitary cortical lesion and just some perilesional edema, no midline shift, nothing, then I think it's fair enough to start on the systemic therapy
Okay.
and give some anti-edema measures and see how the patient goes.
Fair enough. I think both of the way I think is extremely correct. It as you said, it very much depends on the location of the the brain mets, and a lot to do with I think these question answer session do not mean much. A lot of decision you take when you see the patient and you see his condition. But nevertheless, I think both the answers are definitely correct, and it depends on multiple factors than just these. So, like this patient on day 15 of starting osimertinib and corticosteroid, patient had resolution of symptoms, and there was some decrease in the size of lesion. So this is the part. These guys did not address the brain and gave only osimertinib. Okay, and they had, in fact, they are showing it's a complete resolution of lesion. This is being too optimistic, but okay. So if the PET scan is suggestive of brain metastasis, do you do a confirmatory brain MRI, Dr. Ashutosh?
No, sir.
You don't do. Okay. And Dr. Sujna, at your center?
Yeah, we would do, sir, to know the location of so that in future, if the patient progresses, whether they were there before, how much they have progressed, we would get a baseline MRI.
Okay, so I think in our center also we do a baseline MRI. PET scan is also done, but a baseline MRI is also done. So a well-controlled symptomatic brain patient on dexamethasone or anti-epileptics, how long do you continue therapy, or do you prefer SBRT in your patients? I think now the patient is well controlled. He's no longer symptomatic. So would you like to give SBRT, or I think they want to question that you would just like to continue osimertinib? So what would be your take? I think if the patient has a well-controlled brain lesion, I think all of us would like to continue only with osimertinib. Any difference of opinion?
Yes, sir. We would continue and repeat a scan after 1 month and see whether it is decreasing or not.
Very true, very true. So this patient has a very good response. I think let's take it that way, that he responded very well. Okay, so discussion, a study demonstrated efficacy. This we all know that it's very efficacious for the brain lesion. So we'll not go ahead with these details. So do you do brain MRI in asymptomatic patients? So are we following the directions from NCCN, or are we not doing brain MRI regularly? Or is it, because of financial constraints, or what's your take, Dr. Ashutosh?
Sir, if somebody is planned for radical intent, then definitely I think we should do brain MRI. But if it's already a metastatic disease and patient is asymptomatic, I usually don't do.
Acha, you don't do. Okay.
No. If suppose in PET scan it's a florid metastatic disease, but the patient is not having any symptoms for CNS, and I usually don't do it because again, sir, cost adds up every time.
Agreed. I think Dr. Shrujna, you must be doing it in GCI.
Yes, sir. We would do it.
Okay, so how you treat patient with asymptomatic CNS metastasis? I think we all have discussed this. We treat only with osimertinib. So this is the guideline. I think this we all are aware of. Okay, so it's done. Okay, so I think any questions from any one of you, I think we can just shoot few questions and discuss. It's been a very interesting discussion. I'll just stop sharing.
Sir, if may I just want an opinion regarding the the use of adjuvant osimertinib from other centers as well, because it is very financially challenging to give a patient continuously this drug for 3 years, because none of mostly I don't know, as far as I can recall, none of the trials have a treatment duration of 3 years. So what is all of your take on it? Because be it the keynote trials or others, or even in stage 4 we have had, or the durvalumab data also for the Pacific trial as well, it is usually 1 year treatment strategy that we take up. So how would we manage, even if it's a place where we can write and somehow manage and struggle to get the drugs, but is it worth giving a try for 3 years? Because currently I have one patient, so I would like to have all of your advice and opinion on this.
Okay, Dr. Srijna, I think you have given.
Sir, if the finance is not an issue for the patient, I would definitely advise for adjuvant postmortem if it is stage 3. In stage 2, I would not push much for it because the magnitude of benefit is not that much. But stage 3 patients should definitely undergo, seeing that hazard ratio of 0.18, because these patients are going to recur sooner or later. To be frank, it is sooner. So why not start early and decrease the burden of the disease and decrease the disease-free survival and give a quality life to the patient?
I think theoretically we all will agree with it, but you have a very practical problem, so that's a different one. Dr. Ashutosh, your comments, please.
I am not very much fan of the Adara trial, sir.
Okay.
Because there is a lot of fallacies in that trial. One is the patients were not properly staged. Many of the patients were not getting systemic therapies. And despite all these fallacies, they have still not been able to show OS benefit in a lung cancer. So in lung cancer, if somebody is not being able to show OS benefit, I don't get it. Because if you see the durvalumab data, there's a doubling of OS even in a span of 4 years. So it's not like a very ambient disease where you will get a OS benefit after 10 years. No. Something is wrong with that trial, and I personally don't believe that adjuvant osimertinib should be practiced in a regular way.
Okay, so I think if price is the constraint, then adjuvant chemotherapy still holds the ground.
Yeah, definitely, sir.
So in fact, I am also slightly swayed, and I believe all of you, and even Dr. Sukla said that probably stage 2, what you said makes a lot of sense, and then we can.
And in a adjuvant setting, to have a DFS in a lung cancer as a primary endpoint doesn't make a sense.
I fully agree with you. I fully
Yeah,
agree.
yes, sir. Agreed.
So I hope you got your answer.
Yes, sir. Thank you so much.
Okay. So, okay. So any further questions?
Just I would like to make one point. For the EGFR and PDL1, if there were two markers, for PDL1 positive patients, I would prefer to wait for the EGFR, because once we give the immunotherapy, if we detect that the patient is EGFR mutated, the gap between the immuno and the osmotic should be around again 6 to 8 weeks, because the risk for pneumonitis increases. So that is one of the major concerns which is against starting the immunotherapy in the first line, irrespective if we don't have an EGFR report with us.
In fact, very true. The only report I really wait is an EGFR report. So and probably we get it also. I think turnaround time is around 4 days or 5 days. We get EGFR, we get it right away. I think practically that's one report I need to see before starting anything. So that's my take. Anything else?
I think, sir, we have trial of EGFR, TKI, and immunotherapy in head and neck cancer now. They are being given simultaneously in
Okay.
OMC and nivolumab, the trial from the TMH. And in that, they have not reported any of the adverse event in the form of ILDs, grade 3, grade 4, which has hampered the interruption of the drug or anything. So I think previously, yes, this was a concern, but nowadays, I think there is a lot of people won't be hesitant to switch from immunotherapy to EGFR TKI, even if somebody started off and they get the report afterwards.
I fully agree, but you see, both it's hardly a matter of a day or so. I think.
I agree. I agree, sir, that we should wait for it. But if
Okay,
somebody
but
is,
okay, the concept.
yeah, the concept of it. So people have now started using immunotherapy and EGFR TKI together also.
Okay. No, like as I told you, even my experience with good amount of immunotherapy is that I didn't face much, but definitely I have not used TKI along with IO. Definitely, as we are learning today, maybe next time we will be much more wiser. So that's a wonderful point, and I think that is the take-home message, that there's something new that we learned today, that it's not a big deal, you know. So let's see how things evolve. Very nice, very nice. So anything else? I think then we should call it a day. I think wonderful discussion, and could learn a lot of things today. So thank you, Dr. Sujana, Dr. Ashutosh, Dr. Upasana, and I think everybody. It was just an amazing experience. So thank you, the organizing team. Thank you for this lovely evening.
Thank you, sir.
Thank you, sir.
Thank you. Bye.